going to give it just a minute and I'll go ahead and get started because I've got a lot of stuff to cover in a limited amount of time. You can talk for one more minute. Are we ready to start recording? Yeah, okay, great. Is everybody okay if I go ahead and get started? Yeah, okay. All right, so thank you everyone for coming during your lunch break. I really appreciate the support and the interest in learning some more about one of my favorite topics. Before I start, I just want to kind of give a little disclaimer here that I took this really broad topic and tried to determine what different themes within heparin to incorporate and how to balance it between sort of a back to basics review for those of us, like some of our PGY1s who have limited experience with heparin, but I also tried to incorporate some new information about some special populations. And so my hope is that this doesn't feel very disjointed or kind of like a run through the weeds. So just as we kind of move through this, my goal was really to take a lot of the questions that I've received since we started our retrospective heparin monitoring process, and then organize those in a way that sort of takes us a little bit back through the basics and shows us where we've come in terms of heparin dosing, how pharmacists have been and are going to be involved in that, and then what are some things that are coming on the horizon in terms of monitoring the drug. I have no disclosures. So we're going to go through this, and I've made these objectives pretty broad for those reasons I mentioned, but we're going to review and hopefully the listener will be able to identify and summarize the emerging evidence supporting pharmacist-driven management of heparin infusions, to also recognize current gaps in heparin management at our facility, and to apply knowledge of heparin pharmacokinetic principles in our own protocols to achieve effective and safe heparin lab targets in various patient populations. Here are a few of the definitions that I'll be using throughout. Some we're familiar with: PTT, anti-10A, but also we'll talk a bit about antithrombin deficiency and length of stay. So unfractionated heparin was discovered in 1967, and it's since become the cornerstone of anticoagulation for hospitalized patients because of its efficacy, its widespread availability, our familiarity with it, and the enormous volume of literature describing its use for many different thrombotic indications. But despite its efficacy, intravenously administered unfractionated heparin has a narrow therapeutic range and a high interpatient pharmacokinetic variability, which necessitates, of course, frequent lab monitoring. But while literature describing the use of unfractionated heparin IV infusions is ubiquitous, as healthcare professionals, we still have not yet mastered the management of this drug. This is evidenced by the widely reported incidence of drug errors, bleeding events, and repeated attempts to optimize infusion protocols in the medical literature. So pharmacist expertise then is in this pharmacokinetic knowledge makes us uniquely positioned to act as a liaison between the inpatient team members, physicians, and nurses to help manage the drug effectively and safely. And more than that, pharmacist-directed heparin management protocols are becoming an emerging area of interest. We've always been sort of helpful in developing protocols, but these have widely been nursing driven since the 1990s. But a few years back, Joint Commission accredited hospitals were tasked with developing methods to increase anticoag safety. So in that initiative, they actually highlighted pharmacists as key players in helping hospitals achieve that goal. Over time, institutions battling with prevention of heparin dosing errors and enhancing drug safety have investigated various different heparin dosing algorithms. And so we've moved from physician dosing to involvement of other key healthcare team members. The first nurse-driven unfractionated heparin dosing protocol was described in the medical literature in 1993. And in this early study, it was shown that bedside nurses could not only effectively manage these infusions and kind of take that burden off of the physician staff, but also in a safer way. So they looked at some lab endpoints, And I want to kind of emphasize when I start talking about the outcomes they looked at in these studies, that's really key to where we're going with heparin management as a profession. But in that early study where nurses were kind of taking over the brunt of managing heparin titrations, they were able to show, importantly, a shorter time to achieving a first therapeutic PTT value, and also increased the amount of time that PTT values were in therapeutic range for those patients on infusions. And since that initial published study, the following research has really just been small retrospective studies. They've not been very good quality, and they all have pretty much assessed different outcomes because we haven't really established what is the key outcome for measuring heparin efficacy and safety. So in a nutshell, though, with nursing-driven management, we saw essentially nomogram compliance became the biggest area of success versus physician-led care. And so what's important to understand as we move through the CV or the CE and review these studies together is that we do not yet understand in the medical field what is the most accurate manner of measuring heparin safety and efficacy in terms of laboratory tests. And we do not fully understand how best to relate those laboratory results with clinical outcomes, like bleeding and prevention of recurrent thromboses. So while increased nomogram compliance is an obvious goal, subjective outcomes of nomogram studies are not relevant to us if we don't also take into the context their impact on clinical results. So many providers and pharmacists who are feeling frustrated with management might ask, well, what's with all the concern for heparin lab monitoring? As pharmacists, can we really make a difference? And it has been demonstrated that failing to achieve adequate anticoagulation, so a therapeutic PTT or anti-10A level within 24 hours of initiating therapy, actually significantly increases the risk of thrombotic recurrence or clot progression. And so it's not as simple as just selecting the appropriate initial dose, determining this dose and subsequent titrations to the target PTT. And because of this, the topic of heparin management may be best suited to those with specialized drug knowledge who can realize when to be on the lookout for variable pharmacokinetic issues or pharmacodynamic problems that exist in this drug from patient to patient. So similar to that studies of nurse-driven heparin protocols, studies examining pharmacist management also show some of those same improved outcomes. So can we do better? Would pharmacist management of heparin infusions provide an opportunity for increased nomogram compliance and lab targets beyond that of our nursing colleagues? Although the volume of research examining outcomes with pharmacist managed heparin infusions compared with nurse and physician-driven care is relatively limited, the outcomes have been impressive. To name a few, shortened time to therapeutic PTT, increased time within that target PTT range, reduced incidence of bleeding, more timely response to lab results, which I think we have all seen through this recent initiative that we've started in the pharmacy department, and even early recognition of adverse events like heparin-induced thrombocytopenia. So next, I'd like to sort of show you the volume of literature that's been published looking at pharmacist-assisted or pharmacist-driven heparin management compared to provider-driven care. And yes, these 5 studies are primarily the studies that are available for us to sort of take away some of the big ideas that we still use in practice today for heparin management. And so you can see that since 1983, when Chanella et al., or Chanella and colleagues reported on involvement of pharmacists in heparin management versus provider nomograms, the number of studies following that is pretty scarce and dropped off after 2004. Each of these studies assessed the primary outcomes of rates of therapeutic PTT at 24 hours, which is important, and time to goal PTT on average. So in the initial 1983 study, we really didn't see meaningful differences in the outcomes between pharmacist-managed heparin and physician-managed heparin. But we have to think about that during this time, dosing standards for heparin were much different. So in the 1980s, heparin was really dosed based on a fixed initial infusion rate. So we didn't know yet that weight-based dosing was associated with better outcomes. So it's maybe not surprising that there was no difference in those outcomes. But in 1985, Saya and colleagues found that pharmacist-managed heparin was associated with a trend towards achieving these outcomes. In 1992, Pawlowski and his team published a study during a time when fixed rate heparin infusions were starting to become less common, and weight-based heparin infusions were becoming adopted and soon to become the standard of care. And so when they compared pharmacist and physician-led heparin management, they saw that there was a significant reduction in the time it took to achieve the goal PTT, as well as rates of PTT therapeutic at 24 hours. Then in 1999, a much larger study by Mamdani published some new findings that echoed those of Pawlowski and his team. So again, showing increased rates of labs therapeutic at 24 hours, but also they demonstrated a decreased length of stay in patients in the pharmacist-driven group who were being bridged to warfarin therapy. So that's a really key finding. And then moving forward to 2004, again, they saw the same outcomes. Pharmacists do a really great job at adjusting rates, responding to labs, making sure we achieve those targets quickly. They also observed a decrease in patient mortality, and this really applied to patients who were being transitioned to warfarin. And we all know that since 2004, our use of warfarin has dramatically dropped off. And so that may or may not be a finding that could be replicated in today's studies. So now that we know that background of history, I want to take a look at some of our own stats from a medication use evaluation that was conducted a couple of years ago. And I would like to thank Jessie for her very hard work she did in collecting this data and kind of leading the charge to make some changes in our protocols. This chart is displaying the time to therapeutic PTT in patients receiving heparin infusions for different indications, and comparing Erlanger's rates in the gray chart, or the dark gray chart to the far right, to some of those studies that we just looked at and some others that report on this particular outcome. So you can see that, I mentioned that the time of therapeutic PTT that is important for improved clinical outcomes is achieving that mark within less than 24 hours. And so you can see here that Erlanger's doing that pretty well. But you have to keep in mind this was one snapshot in time, one period of time. But this was done in a time when, of course, we have nursing-driven weight-based protocols. But those are some pretty positive results. When we look at comparative time in range over time, I'm comparing our rates to a large similar study that looked at these same outcomes at an academic medical center that also used a nurse-driven heparin algorithm, who reported a time in PTT range on average in their large population of 39%. And this is just really to show you that we are kind of imitating that rate. And so I can't really say that there is a threshold or a standard that we're trying to achieve in the literature. And we don't really know what time and target PTT range means clinically. And the assumption that is the more time we spend in range, the better we are managing our patients and the safer this therapy is. But we have historically been on par with other nationally published data. And then this is just a spread of the different protocols that we use. So if you're not familiar, we have 4 protocols that are guided by a heparin calculator that is embedded into the electronic medical record that helps calculate doses for us. It's not foolproof and error-proof, but in the dark purple color, this is just kind of showing the percent time and range for total protocols, and then which was 38%. And then that's broken down by different protocols. So CT surgery was a little bit higher at 45% of collected PTTs were within therapeutic range, low dose protocol and standard dose protocol. So most of the time when our patients are not within therapeutic range, they're more likely to have a subtherapeutic PTT. And then one other major outcome that I want to compare that's commonly looked at in studies is the overall compliance with a heparin nomogram. Just historically looking on your left at the studies that were conducted that I reviewed briefly, they report overall compliance rates of 43.9% in one study published in 1999. So remember in that study where we compared pharmacist management to physician management, we did see some improved lab outcomes, but That was in the face of 43% protocol compliance. And then overall compliance in the more recent study at a facility similar to ours with a nursing-driven protocol was 84.6%. And then in our 2021 evaluation at Erlanger, we didn't look at overall protocol compliance. We thought it would be more useful to break that down into the different components or the areas of compliance. So if you look at the purple bar, you can see that 96% of the time, the appropriate initial infusion rate is selected. And that makes sense because the nurse at bedside is guided to select the infusion rate to start based on the protocol selected by the provider. What I really want to point out is that we don't do a great job at administering PRN bolus doses when they're indicated for subtherapeutic PTTs. And we don't do a really great job at making sure that when our PTTs result, adjustments to the rate of infusion are made at the bedside within 1 hour of that result. Are these areas where a pharmacist-led program could help? I think those are some questions that we would like to see answered. And I think those are some questions that we've really seen answered and we've seen improvements on in the last couple of months as we've rolled out this retrospective monitoring process in our department. All right, so I'm going to slow down. I know I talk really fast. I've just got a lot to cover and do a really simple knowledge check. So please shout it out. The most common metric used for reporting on heparin efficacy and safety is rates of compliance, therapeutic PTT within 24 hours, rates of thrombotic events or rates of major bleeding events. So this is going to be our most significant marker for success. And interestingly, it really only applies when it's for the indication of DVT treatment, right? So we know that there's less risk of progression of a clot or recurrence when we achieve it quickly. The jury's kind of still out on heparin infusions that are used for other types of indications. All right, so that is all I'm going to say about the review of the history of heparin literature. You can see that that didn't answer a lot of questions for us. So now I want to talk more about things that are very pharmacist specific. And the first part of this is just going to be kind of going back to basics. Why is heparin so difficult to manage? Every pharmacist who has participated in this retrospective review process has been very frustrated by the number of times we see a PTT therapeutic for 2 days, and then on day 3, it's not. What's going on? Did we do something wrong? Can we do better? So unfractionated heparin, we know, is a polysaccharide polymer isolated from porcine intestine cells. Its length can vary, which is one thing that contributes to why there is variability in its effect. And it works by binding to antithrombin 3. And this binding is going to accelerate the interactions between antithrombin, thrombin being 2A, and to accelerate those actions between those and factor 10A. And that's subsequently going to inhibit prothrombin activity, which blocks the final step in the pathway of clot formation. And an IV bolus dose of unfractionated heparin does have an immediate effect on accelerating the formation of that heparin AT3 complex, which is going to cause inactivation of those coagulation enzymes. But thrombin and 10A are going to be the ones that are most sensitive to the effects of that compound. The pharmacokinetics of unfractionated heparin are unpredictable because in circulation, it binds to a number of non-specific plasma proteins, endothelial cells, and macrophages, and has variable clearance. And so this non-specific binding can reduce heparin's anticoagulant activity at low concentrations. And other variables like heparin neutralizing proteins, macrophage elimination mechanisms, our baseline antithrombin levels, a patient's clot burden, a patient's volume of blood distribution, weight, so presence of obesity, and even the patient's age, all are factors that contribute to the variable and unpredictable response to heparin between each patient. So this knowledge becomes especially important when pharmacists are the ones faced with assessing for, why we are having difficulty with a given patient getting their heparin labs under control or to be stable and therapeutic, or whether there might be another underlying problem like the presence of heparin resistance. All right, so now we're going to go into dosing. And as I speak about dosing, we're going to talk about just the 3 primary indications. We're not really looking at some of our more complex patients like critical care, trauma, vascular surgery. My goal is really to talk about dosing in the context of what we will be seeing most commonly as we move to pharmacy-based heparin dosing as a system. All right, so bear with me. I think it's important to go through a brief history of dosing of heparin. As I set out to kind of gain enough knowledge to let you guys know why we do the things we do, I became really frustrated trying to figure out where our target lab goals even come from. Why do we target a PTT of 60 to 85 for our standard protocol? Why don't we use anti-10A levels? So back in 1972, there was a very popular study called, by Basu and his team that looked at rates of VTE recurrence using a fixed rate heparin protocol between no lab target and a lab target of 1.5 to 2.5 times the control PTT. Where did they get 1.5 to 2.5? This study is where all of the guidelines published thereafter have cited that range from. And so Basu determined that that was their target range because that is what correlated with a heparin anti-10A level of 0.3 to 0.7 at their facility using their lab analyzers. That recommendation was carried forward in 1989 when the ACCP guidelines for VTE treatment recommended this similar dosing approach of one bolus followed by 1,000 units per hour. In 1992, if you'll remember, we started moving towards investigation of weight-based dosing rather than just one fixed dose for all patients. And it became clear that some patients might benefit from higher doses to achieve those target lab ranges. And so they expanded that initial bolus dose and that initial infusion rate up to 10,000 units for a bolus and 1,300 units per hour infusion. Then this study by Rashki and colleagues in 1993 is where we get the textbook package insert dosing for heparin still today. They came up with a nomogram to be to start with an initial dose of 80 units per kilogram intravenously for the indication of DVT treatment, and then to start that infusion at 18 units per kilogram per hour and targeted to a PTT of 1.5 to 2 times the patient's baseline. And in 1995, because of those improved outcomes they saw on those lab markers, we saw an updated recommendation of either a fixed dose infusion or a weight-based dose infusion. So you can see we're really basing our changes and our recommendations on this topic to data that's not that strong, and that's been carried through for decades. And then finally, the most recent update to heparin treatment in 2012 was published again in the ACCP VTE guidelines, and they recommended a fixed dose infusion of at least 32,000 units per day or a weight-based infusion. And so we see both of these recommendations today in these guidelines. There is a publication by Smythe and colleagues in the Journal of Thrombosis and Thrombolysis from 2016 that is one of the most comprehensive reviews of unfractionated heparin and low molecular weight heparin practice. It summarizes some of the most current evidence. And in this article, the authors say that we suggest that total body weight be obtained prior to initiating heparin, and your initial dose is more important than the APTT in predicting efficacy. And we suggest that heparin dosing be guided by a dosing adjustment nomogram, but they point out more research is needed to identify how we should monitor unfractionated heparin. That was in 2016. So although the use of a weight-based rather than fixed regimen is recommended by guidelines, there's no data to recommend one particular type of nomogram. The comparative studies of each of these dosing approaches are lacking. So every institution kind of has to rely on nomograms that have been employed in clinical studies. So that Rashki nomogram used actual body weight. So that's where that recommendation comes from. But there are no studies that have compared outcomes using different weight-based strategies. And I think it's important to note that in that study, only 8% of patients had a weight over 100 kilograms, and the range in the study was up to 131 kilograms. Importantly also, although protocols based on total body weight may have shown in the past that patients who are obese who receive heparin based on total body weight are more likely to have a PTT above goal, there has not been any increased rates of bleeding associated with that practice. And so we have to consider that really what we know is that one of the most important things for achieving adequate anticoagulation is to do that quickly. Current heparin infusion dosing recommendations for the most broad categories then are as follows. For VTE, we have that same weight-based dose recommended by the Roschke study with a maximum initial bolus dose of 10,000 units. And the recommendations for treatment of acute coronary syndromes differ depending on which publication you're going off of. The main difference between ACS chest guidelines and ACS European Society of Cardiology guidelines are that the European Society of Cardiology does permit a higher initial loading dose for patients receiving heparin for acute coronary syndromes. And we have recently updated our order set at Erlanger to reflect this. So 60 units per kilogram bolus followed by 12 units per kilogram per hour with a max bolus of 5,000. Here's just a simple overview of our heparin protocols. I was asked if I would review this today. I would just like to point out that right now, as a pharmacy-driven process for retrospective monitoring and going forward when we begin our prospective monitoring and dosing protocol, we will still use these 4 protocols. And so at this time, we are not extrapolating or expanding this to CRRT or ECMO heparin management. But these protocols are available to be viewed on the X Drive. They are updated and can be shared with our nursing and provider staff. All right, and just to touch on those special populations of patients who are at the extremes of weight, I mentioned that in patients who are over 100 kilos, we haven't seen increased rates of bleeding when dosing on total body weight. So for patients who weigh between 50 and 100 kilograms, we know that actual body weight is preferred. For patients who weigh greater than 100 or 150 kilograms, they have BMI over 30 to 35. Actual body weight, based on current available literature, is still preferred, but expert opinion does state that you can consider using adjusted body weight. And where I really think that comes from is we have to acknowledge that although the majority of the studies on heparin monitoring are done in patients with thromboembolic disease, we use heparin for a myriad of other types of indications. And so I think we have to acknowledge that although achieving the goal PTT as quickly as possible is important for the treatment of acute thrombotic indication, that may not necessarily be the goal for some other indications. For example, a patient without history of recent thromboembolic disease, maybe they're having their anticoagulation held for a temporary period of time while they undergo a surgical procedure. You know, is it necessary to use total body weight in that situation? I don't think we really know. But I think as pharmacists, we have to understand when to use our clinical gestalt and to understand that it's not a one size fits all. And I think that's one point, or one of those frustrating points I've received feedback on, is we want everything to be very black and white with the protocols. But that's why, as the drug experts, as pharmacists, we're involved in this, because we need to recognize when it's not that straightforward. For patients at low body weight, less than 50 kilograms, we have seen in some very small studies that these patients are more likely to need a lower dose of heparin. And that's probably because they have a predominance of adipose tissue over muscle tissue. And there is likely to be reduced drug volume of distribution in elderly patients or patients of low body weight because of that. And so the risk of excessive dosing of heparin is a risk in those patients. All right, another knowledge check. We have TS, who is a 33-year-old female presenting to the emergency room with shortness of breath and a fever. No observed risk factors for bleeding. On chest CT, it's noted that there is a bilateral pulmonary embolism. This patient weighs 190 kilograms. Ideal weight is 82. Blood pressure is a little bit soft, slightly tachycardic with normal baseline coagulation parameters. The physician places an order for the reduced heparin infusion without an initial bolus. Based on guideline recommendations that we just reviewed, is this an appropriate regimen for a patient with acute thromboembolism? Who says A? Who says B? Who has more questions? So in this situation, I said, no, this patient has a large pulmonary embolism, so high clot burden. They're not necessarily hypotensive, but we don't know much about their clinical stability over the next several hours. And they're a little bit tachycardic. With the data that suggests that there is a benefit, a safety benefit, and an efficacy benefit to achieving a therapeutic PTT within the first 24 hours. And the fact that we combine this with the lack of evidence of increased rates of bleeding in obese patients who receive total body weight dosed heparin, my personal professional opinion would be that this patient should be started on a high dose or, standard dose protocol with a bolus. Upon further investigation, you determine that the physician selected the reduced dose protocol and omitted the initial bolus because of concern for excessive heparin dosing due to their weight. How would you respond? Heparin dosing based on actual body weight and obesity is not associated with increased rates of bleeding, but may increase the risk of therapy failure. So let's provide an initial bolus dose and change to the standard protocol. Or would you say B, recommend to give the initial bolus dose and continue with reduced dose protocol using their adjusted body weight so we prevent excessive anticoagulation? Or would you recommend to switch to enoxaparin to simplify things? So we would not recommend to switch this patient to Lovenox because of their body weight for similar reasons. And at least not in the acute setting of a patient who may be decompensating. So that was my rationale for this one. I would suggest that the provider go to A. Now, what if this patient has a history of a recent bleed? We have to look at the chart and consider the background, the patient-specific factors. So this is an easy question on paper, but there would be more questions because I need to know more about that patient's history before I make a decision. All right. This is maybe my favorite part of the presentation and one that maybe will hopefully raise some eyebrows among our clinical pharmacists in the room. This was an enormous point of learning for me. I have been a PTT girl since I started learning about heparin, and maybe some of that's because I never had an opportunity to use an anti-10A monitoring protocol. So I want to investigate, what information is out there and what should we be doing? So in that article I referenced earlier, it was recommended by Smythe and colleagues that either the PTT or heparin anti-10A level monitoring may be used. We suggest using an anti-10A level monitoring in patients with heparin resistance or a prolonged baseline PTT or altered heparin responsiveness. And they say to check those levels every 6 hours until 2 consecutive results. All right, sorry, another timeline. So why do we do this? After Basu's 1972 study, animal studies then demonstrated prevention of thrombus extension with his PTT goal range of 1.5 to 2 times the control. So they quoted, when patients are treated with initial heparin infusion of at least 30,000 units per day in that weight-based range, it is uncertain if adjustment of heparin dose in response to the PTT improves the efficacy or safety. And there are no recent trials that have evaluated unmonitored continuous heparin infusions with different levels of anticoagulation. So the benefit of monitoring IV heparin once we've established that therapeutic threshold is not well defined. Evidence supporting it is weak. And I would like to point out here also that subcutaneous heparin does not require any lab monitoring. So in 1996, the reason that those dosing guidelines changed the way they did was because higher doses of heparin were associated with improved lab values and clinical values. And again, we just to point out here that it is so important to achieve those lab values quickly, but we don't really know what the significance is after 48 hours of dosing. All right, so what are our options for monitoring? We have the PTT, or partial thromboplastin time, the anti-10A level, or ACT, which is activated clotting time. The activated partial thromboplastin time, or PTT, measures clotting time. It's reported in seconds, and it's sort of a surrogate marker for the functionality of our anticoagulation pathways, but it's not always reliable. Its results can be skewed by biologic factors, especially acute phase reactants. So those that's concerning for patients with acute critical illness or those who have sustained traumatic injuries, and also by patients who may be receiving like CRRT or ECMO and who have an extracorporeal device. They're not very elevated in terms of reliability for estimating the serum heparin concentration for patients who have elevated factor VIII or fibrinogen, antiphospholipid antibody syndrome, antithrombin deficiency, or very high levels of heparin that you may see during cardiac procedures, for example. And clinical studies report their therapeutic value based on their difference from their control sample. And so that's usually 1.5 to 2.5 their control. The anti-10A level works a little bit differently. It's not measuring the endpoint of clot formation. It's a chromogenic assay. It's a direct measure of heparin activity, and it's less variable than the PTT. It's not affected by acute phase reactants, but like the PTT, it is still susceptible to low antithrombin levels. And so that's a major consideration given the patient population we frequently care for here at Erlanger. The target range for VTE treatment and for most other indications outside of acute coronary syndromes is 0.3 to 0.7 units per milliliter, but that optimal therapeutic range has been debated. And finally, the activated clotting time. This is something as pharmacists we really don't see. This is primarily used during procedures where patients are exposed to higher doses of heparin intraprocedurally because the PTT becomes less accurate as the dose of heparin increases. So which team are you on? Raise your hand if you vote for PTT monitoring. Raise your hand if you vote for anti-10A monitoring. All right, so please keep in mind, this could have been its own CE topic. So I've got to condense everything, but data that would support use of anti-10A monitoring for heparin infusion dosing have summarized that when you use 10A monitoring, there is a reduced time to achieving a therapeutic value as compared to the PTT. Authors of these studies have also stated that fewer samples may be required or fewer blood draws than when you use PTT. Also, something that's interesting is that PTT results can be skewed by the concentration of blood, or not the concentration, the volume in the lab tube. So reduced tube volume is going to potentially skew your PTT result. It's been said that they are more stable versus PTTs, and there are established protocols for 10A monitoring. And there is actually a pretty decent percentage of inpatient facilities across the nation that exclusively use anti-10A monitoring. So what are the limitations? Why aren't we doing this? Well, PTT concentrations have not shown to be predictive of anti-10A concentrations, and there's up to 60% discordance reported in studies that have looked at some of these outcomes. It has a much higher analytical cost. So the cost most recently from our lab was $30 for an anti-10A level compared to $2 for a PTT level. They also are susceptible to reduced accuracy in some patients. So patients who have hypertriglyceridemia, recent factor 10A inhibitor use, which is one of the biggest issues to me because of the prevalence of use of these agents, hyperbilirubinemia, or delay to the lab by more than 1 hour. And there is a lack of robust data that associates a specific anti-10A target range with actual clinical outcomes. So let's look at a recent study that I think that was done very well. It's one of the more prospective studies to evaluate laboratory and administration outcomes between anti-10A monitoring and PTT. So this was conducted at UPMC, which is a large academic medical center. It was conducted between March and June 2015. So they collected data on about 200 patients at their facility, and they wanted to assess whether there was a clinical and economic benefit that would support their institution switching over from PTT to 10A monitoring. So they looked at things like the time to achieve a therapeutic 10A level versus the PTT, and also whether there was any benefit for 10A monitoring, like reduced number of heparin infusion, dose adjustments. They looked at the correlation of those lab results and rates of bleeding and thrombosis. And they assessed these outcomes by comparing a retrospective group of patients that received PTT-guided heparin dosing versus a prospective arm of patients that got 10A guided dosing. So on the left, this chart is just showing all of the different indications that heparin was used for in the patients that they studied. There was 100 patients more or less in each group. And the chart on the right, if you look at the y-axis, you're looking at the percent of therapeutic PTT measurements over time as we move to the right. And so looking at this, you see that across all time points, anti-10A levels were more likely to be within the therapeutic range, even past the 48-hour mark. Specifically, the average time to therapeutic range in the PTT, the average time to therapeutic PTT was 24 hours in that group, compared to only 16 hours in the anti-10A group, and that was a statistically significant finding. Do you remember what the time to therapeutic PTT is at Erlanger? 15 hours. If you remember from previous slides, our time to therapeutic range is around 15 to 18 hours, depending on the protocol. So that's better than the historic cohort in this nomogram. And I found it interesting that there was no observed difference in the number of lab tests performed per day between groups or the number of lab tests performed overall. And finally, the number of heparin dose adjustments required every 24 hours, while statistically fewer in the anti-10A group, was arguably not clinically meaningful. And the authors reported this finding as one less dose adjustment for every 3.3 days on treatment with anti-10A monitoring. And I'm still not completely convinced about the significance of monitoring the correlation between these labs, but it's just another factor that kind of gives us pause as healthcare professionals when we are monitoring these labs. In this study, they showed an overall discordance rate of paired 10A and PTT levels at 49%. So 35% of the time that these levels were checked, the therapeutic 10A level agreed with a therapeutic PTT level. Some proponents of anti-10A guided management of these infusions suggest that its niche might be in the ICU population due to the increased number of acute factors that can cause variations in those patients' heparin response. In this 2019 study published by Rotano and colleagues, it was one of the largest studies to date in an ICU population. So more than 35,000 sample analyses were included. The investigators conducted this retrospective evaluation in a teaching hospital over a 10-year period to specifically look at laboratory concordance with PTT versus 10A guided heparin management in a mixed ICU population. They did not assess clinical outcomes, but they highlighted an observed lack of agreement between PTT and 10A monitoring. Sorry, hang on just a second. And so the main summary of this study was basically that it may be a little bit too early to recommend 10A monitoring versus PTT monitoring in these patients, but that the jury's kind of still out on which one of these would be more accurate. We have the history of studies with PTT guided dosing protocols that gives us some comfortability among provider dosing, pharmacist management, observed rates of bleeding outcomes in this population. And so it was kind of difficult to find some confidence in seeing the rates of discordance between those groups. So 40% of anti-10A levels were discordant with a measured PTT. It was more, or the PTT was higher than the 10A in 30% of patients and lower than the anti-10A level in 10% of patients. They did note, and specifically in patients on ECMO or CRRT, that the PTT was likely to be higher than the anti-10A level that was measured. And they think that may be just because of the binding of the drug to those device surfaces, which can activate the coagulation contact pathway. Then a study by Elsie and colleagues in 2018 looked at specifically at vascular surgery patients. And they echoed the sentiment of Rotano's study, although this one was much smaller. Instead of evaluating numbers of lab samples, they looked at 134 unique patients at a single facility that had pharmacist dose heparin. And they wanted to look at the rates of discordance between anti-10A and PTT monitoring and then determine if there was any correlation with rates of bleeding between those two. And in this small analysis, they observed that the rates of major and minor bleeding were not significantly different. but were numerically higher in the anti-10A managed group. So despite this increased rate in major bleeding observed, there was no difference in rates of transfusion requirements. So the authors concluded that in vascular surgery patients, they may be at increased risk of bleeding when higher PTT levels correspond to 10A levels within the specified therapeutic range. So does the cost of anti-10A monitoring outweigh the clinical differences? The idea of an overall net neutral cost between these modalities is controversial. To date, no study has established a clear clinical benefit with 10A monitoring over PTT monitoring because this is difficult to ascertain in terms of thrombosis and bleeding rates. So recent research focuses on clinical and lab outcomes that are easier to quantify. So an example of this is this 2020 VA study by Kendallin and colleagues. They looked at about 200 patients that were getting heparin infusions for unfractionated heparin and ACS indications. And they wanted to determine if anti-10A monitoring posed advantages to the institution in terms of their lab use and administrative burdens. So 103 patients were examined on heparin infusions receiving PTT-driven care versus 100 on anti-10A-driven care. Their protocol was like ours. They did not use a calculator. They used a calculator to eliminate dosing errors or risk of dosing errors, weight-based, nurse-driven nomogram. So the current standard of care. And so the outcomes of this study showed fewer dose adjustments per day in the anti-10A group. Although it was statistically significant, you can see that here we're talking about 0.7 dose adjustments per day on average compared to 1.2. And there were higher rates of use of medication, so more bolus dose administration used in the PTT group after having to pause therapy for a prior elevated level, but they did not report on other clinical outcomes. So to anti-10A or not, I will just leave you with this. Therapeutic targets are reached faster with anti-10A nomograms. The reduced daily lab utilization, though, has not been consistently demonstrated. And the reduced frequency of unfractionated heparin daily dose adjustments may not be clinically significant, and that may be dependent on facility and patient intervariability. And there are inherent analytical limitations to both tests that may skew results. And we do not know yet how to correlate the differences between measurements in these lab parameters and clinical outcomes. And there is a very significant cost difference. All right. So finally, looking at one big major area of heparin troubleshooting, I've received a lot of questions and been looped in to help with a lot of cases where patients seem to not be able to achieve therapeutic PTT levels despite increasing rates of heparin. And so heparin resistance is common, especially in some of our critically ill patients or trauma patients. And it's very generically defined as failure to achieve therapeutic lab targets despite high doses of heparin. And one study defined this as at least 35,000 units of heparin per day. And so one of the most common reasons for resistance in the acute care setting is reduced levels or activity of circulating antithrombin because heparin's anticoagulant activity is dependent on the ability to promote antithrombin's activity. Under normal circumstances, exogenously administered heparin is going to interact with antithrombin and augment its anticoagulation function by 1,000-fold. So if AT3 amount or function is impaired, then your heparin binding is going to be reduced. Mechanisms by which this occurs are, as I kind of showed you before, the fact that heparin has a lot of nonspecific binding, presence of antithrombin deficiency, platelet interactions, or patients who may have baseline elevated levels of coagulation factors like factor VIII and fibrinogen. Acquired antithrombin deficiency in critical care. This phenomenon of hypercoagulability in patients with severe traumatic injury is well described, and more than half of trauma patients will develop some degree of antithrombin deficiency. It's more likely to occur with higher injury severity scores. And the standard of care for treatment in these patients with antithrombin deficiency is not really well defined. But we do see that this is also commonly presents in patients with sepsis, and it's going to manifest as heparin resistance. So just failure to achieve those therapeutic anticoagulation doses over a a timeline of days. And so once that patient's receiving more than 35,000 units of heparin, it's time to consider whether some alternative anticoagulation or further workup would be indicated. So what is recommended by Smythe and colleagues, and what we don't have a well-defined process here for, but nevertheless is the recommendation, would be when there is concern for presence of heparin resistance, as pharmacists, we should be reviewing for doing a clinical review for risk factors. So is the PTT persistently subtherapeutic? Is their heparin dose at least 35,000 units per day or more? Are they at risk for antithrombin deficiency because of some of those previously described characteristics? If so, the management strategy should be to measure a heparin assay. Heparin assay is what our anti-10A level is labeled as in EPIC, if you were to order that. And if we order the unfractionated heparin assay level or the anti-10A level, and it returns at less than 0.3 to 0.7, despite these high doses of heparin resistance is a high possibility. And so at this point, I don't think there's enough evidence to support a protocol of how to approach this. We certainly don't do this as a facility, but this would be a great opportunity to notify someone who may be either rounding with the team or one of our clinical staff members to make sure appropriate lab workup is being done, and we're discussing plans with the provider team. All right, knowledge check. This is for Bree. All patients requiring heparin infusion should be transitioned from APTT to 10A monitoring protocol due to expected heparin resistance.
Preference or?
No. I mean, it can't be if you disagree with my literature. False. Anti-10A monitoring may be preferred over PTT monitoring when all of the above. Finally, BC is a 35-year-old female admitted for a left tibial fracture while going down her water slide. Her lower extremity ultrasound shows an acute DVT in her left perineal vein. PTT is 50, and she is receiving a standard heparin infusion protocol with a PTT goal of 60 to 85. The pharmacist receives a nursing call requesting assistance with dosing, and it may or may not be to the patient directly in the bed. The current heparin infusion rate is 30 units per kilo per hour, and the protocol indicates to increase the rate by 2. The nurse states she receives an EPIC warning when trying to increase the rate of the infusion beyond 30 units per kilogram per hour. What is the correct recommendation based on our current facility protocols? Just continue the current rate and repeat in 6 hours. Increase the rate of infusion as instructed by the protocol and repeat PTT in 6 hours. Notify the MD that alternative anticoagulation orders are needed because this patient has heparin resistance. Bolus and continue the current rate, and then check labs again in 6 hours. Okay. All right, so rounding out here at the finish line, I want to just emphasize that if you feel more confused than ever about what is the standard of monitoring and adjustment and how do we improve these clinical outcomes, the answer is we still don't know. And so we have to base all of our actions and our protocols and our policy on the best available evidence. And the best available evidence at this time, especially for treatment of acute thromboses, is that we need to achieve lab targets quickly. And we can do that by following weight-based protocols, but with close monitoring to conduct surveillance for excessive anticoagulation and adjustment when that's observed, but also when to recognize that although the data to support alternative modes of monitoring like anti-10A monitoring may not be completely proven, we are starting to see data where it may be more or less beneficial in certain patient populations. And so there are some studies that are publishing pharmacist-driven protocols when the standard of dosing and care is PTT-driven dosing. But there are certain conditions in which a pharmacist consulted to dose then has authority to switch over to a 10A monitoring protocol. And so that would be based on observation of some of those factors that we discussed. I think that's certainly an area that I would like to explore. But in the meantime, things that can be enormous barriers for effectively managing heparin as we move through to this new protocol for pharmacy dosed heparin is recognizing every patient is going to have a variable interpatient response. We could all get the same bolus dose and infusion rate of heparin right now, and our labs would be different in 6 hours. Recognize when an incorrect lab draw technique may have resulted in a skewed PTT. How many of you have seen a PTT result at greater than 200 seconds? We call the bedside nursing team and determine that needs to be redrawn because it probably came from the heparin line. So that's a huge area of intervention for pharmacists. Protocol non-adherence, I've seen some really, really great interventions where pharmacists have reached out to our nursing colleagues to either correct the initial starting dose of a heparin infusion or to help kind of navigate what rate to start at in the post-procedural setting. And communication failures can be huge. So I hope that we're going to be overcoming this with our newly implemented EPIC user group, where we've been we basically developed, if you haven't seen this already, come find me after, we should all be using it now, but an EPIC user group called Heparin Communication to Pharmacists that any nurse can use for either the East or main campuses, and it allows them to communicate with a pharmacist who is dosing heparin on any given shift. And so the feedback I've gotten has been really positive for that, and we'll continue to do so. And then finally, temporary therapy interruptions. And this is an area where we don't have a lot of guidance on, and one area we're going to work on in the future in terms of transitions of care from operative areas back to the floors and so forth, to make sure across disciplines we are kind of all in agreement on how to handle these. All right, so just rounding out here with future directions. One thing I'd like to see is determination and more studies of what is the best approach to lab monitoring in really individualized patient populations. We are going to be implementing a pharmacist dose heparin infusion policy at Erlanger. I wish I could give you a start date on that today, but I cannot, but it is in progress. Our hope is that it will further reduce administration and dosing errors. We've seen this already with a huge increase in the number of e-safes that we're reviewing for these types of errors. But it's not yet known if pharmacist involvement actually will have an impact on clinical outcomes, so that remains to be seen and something that we'll be conducting research on. And then future investigations of predictive dosing based on individual factors like age and weight adjustments are something else we need to look into, because I think despite having weight-based protocols, these are still not individualized as much as they could be or should be for our patients. So with all that being said, I am done, and I'm happy to take any questions if anybody wants to ask any with the 5 minutes we have remaining. Yes.
In patients who decide to check the hyperometry level on as the rationale for two pieces of this question. Number one, if they decide to supplement antithrombin 3, find any literature looking at empiric dose reduction of the antithrombin 3 is supplemented?
Mm-hmm.
And number two, you think it's more cost effective to just change to Bival or Gatraban versus continuing?
Yeah, so Bree's asking questions for people who are reviewing this presentation later about whether or not there's reliable literature studies on supplementing antithrombin 3 in patients who have demonstrated antithrombin 3 deficiency. I did not really do a deep dive into that kind of specific patient population, but I did find enough evidence to support the consideration, obviously, of antithrombin 3 replacement, which I'm sure you're very familiar with, but in terms of how to then adjust the heparin infusion subsequently, I did not find anything that gave like a strong opinion or recommendation for subsequent manage of the heparin infusion. That just wasn't a component of any study that I came across at all. I think that would be something really interesting to look at in terms of over time. Of course, we'd have to collect a lot of patients in your patient population to be able to do that, but with pharmacist dosed heparin, that might be something that we could look at and single out some answers. So no, I don't have any good answers for you there. In terms of cost effectiveness, so Bree asked if it would be more cost effective to change to a direct thrombin inhibitor, for example. I think, it would be easy to say yes, but we have to keep in mind that, of course, those direct thrombin inhibitors are non-reversible, right? So if you're talking about a patient that has an elevated risk of bleeding, which is inherent to the surgical patient population, I think I would really have to do a pros and cons analysis to determine if I place a higher priority on anticoagulation or their risk of bleeding. Thank you very much for your time.